Thank you, Susan. Thank you to BU, Center for the Humanities, and especially to Susan and her entire team to putting together this wonderful panel, and for all of you for making it through 2 days. And we'll move on to hopefully a more interactive format shortly. If you can't hear me in the back, let me know. Just raise your hands. I will try to increase the amplification on this. So I'm going to be talking about the second arrow, which is really the relationship between opioid addiction and other mental disorders. The next slide is my disclosures. There's nothing here that's relevant to anything I'll be talking about today. So about 2,500 years ago, the Buddha lived and taught in India. And one of the famous teachings that he had is called the Salata Sutta. Sutta is the term that we more commonly hear as sutra. Sutta is from the Pali Canon. Sutra is from the Sanskrit. And the story of the second arrow is one that has made its way to some degree into American Buddhism as well. So the story goes something like this. An untaught, and this is the Buddha speaking, not me. An untaught disciple or monk experiences pleasant feelings. He experiences painful feelings. And he experiences neutral feelings. A well-taught disciple likewise experiences pleasant, painful, and neutral feelings. Now, what's the distinction and difference that exists here in between a well-taught disciple and an untaught disciple? When an untaught disciple is touched by a painful bodily feeling, he worries and grieves. He laments, beats his breast, weeps, and is distraught. He thus experiences two kinds of feelings, a bodily and a mental feeling. It is as if a man were pierced by an arrow, and following the first piercing, he is hit by a second arrow. So that person will experience... Okay, so, sorry. When an untaught disciple... Make this a little taller. See if this works better. When an untaught disciple is touched by a painful bodily feeling, he worries and grieves, he laments, beats his breast, weeps, and is distraught. He thus experiences two kinds of feelings, a bodily and a mental feeling. It is as if a man were pierced by an arrow, and following the first piercing, he is hit by a second arrow. So that person will experience feelings caused by two arrows. But in the case of a well-taught, noble disciple, O monks, when he is touched by a painful feeling, he will not worry, grieve, nor lament, nor will he beat his breast and weep, nor will he be distraught. It is one kind of feeling he experiences, a bodily one, not a mental feeling. Now, I don't want to talk about Buddhist metapsychology, which is really pretty far afield from where we are in this discussion. But I do think there is something in the reality that when we have pain, we also have reactions to pain. And that not all of us have the same level of reactions to pain, and some other kinds of situations or conditions can indeed moderate or change the kind of pain we have. Indeed, opiates, if you talk to the classic teaching for physicians about what do opiates do, and after all, opiates are most importantly used for the treatment of acute, often surgical pain, pain associated with broken limbs, etc. People may describe that they still feel the pain, it does not bother them as much. So there are complexities to what we think of as pain and our reactions to pain that are important and set us around for the way in which we respond to things. And some of those have to do with individual characteristics, some of those may have to do with group characteristics, and some may also have to do with the state of meaning, purpose, and salience that we experience in other ways in the world. So let's talk a little bit about pain, opioids, and mental disorders. So this is a paper from Alan Schatzberg and colleagues. It was a study looking at pain and depression in a European sample. And the key finding was that in almost 19,000 subjects in the European Union, 43% of individuals who met criteria for major depressive disorder also had what's called a CPPC, chronic painful physical condition, in contrast to 16.1% of the remaining population. So a rate that's about 2.5 times higher. This is a more recent study that was from the Journal of the American Medical Association Pediatric imprint, which came out in 2018, looking at pain, mental health, and adolescence in the United States. A cohort of almost 1.25 million people, opioid recipients without cancer diagnoses aged 14 to 18. All pre-existing mental health conditions and treatments were strongly associated with higher rates of long-term opioid therapy. This is a paper that came out in the Journal of the American Board of Family Medicine, and like all of these papers, these are preliminary kinds of papers. They're based on epidemiologic and other data, but they're interesting and they all seem to point in a particular direction. This is a study looking at opioid prescriptions in patients with mood and anxiety disorders. Adults with mental health conditions receive 51.4%, 60 million of 115 million prescriptions of the total yearly U.S. opioid prescription cohort. Adults with mental health disorders were significantly more likely to use opioids, 18.7% to 5%, with a p-value of 0.001. The 16% of Americans who have mental health disorders receive over half of all the opioids prescribed in the United States. Now, before you think I'm adding to the stigma of substance use by stigmatizing individuals with mental disorders, I'm simply reporting what some data is. The fact that individuals who have what are called mental disorders, and again, not all suffering is mental disorders. What the Buddhists would call dukkha is a form of suffering, is not a mental disorder. Existential suffering isn't necessarily a mental disorder. And mental disorders are not all caused by mental phenomena. What we call mental disorders are disorders of behavior, feeling, choice, experience, action, organization of mental processes, and they can be due to a wide variety of medical, neurologic, and other conditions. So what else do we know as we look at some of the epidemiologic data? So I want to look at some of the data on opioids, suicide, and medical illness, including some data on morbidity and mortality. This is from the New England Journal of Medicine from 2018, this past April. I think I've got the right, now this is, probably really can't see the clicker here. So you can see drug overdose death rates by type of opioid in the United States, 1999 to 2016. And you can see that synthetic opioids other than methadone, heroin, have gone through very, very dramatic increases during that period of time. This is from a number of people have mentioned Angela Case and Angus Deaton, who are economists from Princeton University. They were the ones who first published some of the work in 2015 on deaths of despair. This is from their paper from 2015. And what this shows is what we would call a secular trend, meaning what's happening in the general environment. And this is from 1990 to 2000. This is deaths per 100,000 population. And you can look at all of our comparator countries, Sweden, Australia, Canada, UK, Germany, France. And this is, the death rate, as you can see, is going substantially down over that 20-year period of time. This is US whites. And the rate of death is, US white non-Hispanics, the rate of death is going up, or at least staying high and not going down, as you see for the rest of the secular trend. When you isolate the data a little bit more and you look at mortality by cause between age 45 and 54 in US white non-Hispanics over this period of time from 2000 to 2015, you see that there are several conditions where the rates are either going up dramatically or significantly. The largest growth in the rate is this red line here. That's poisonings. That's the public health term for overdoses. That's the term that's used. The next one, though, we don't talk about as much, but it's almost as dramatic. It's suicides, and have gone up very dramatically. And then the other one is chronic liver diseases, and of course chronic liver diseases are most strongly associated with either viral hepatitis, which in turn is associated with infectious complications associated with needle use, or alcohol use. So again, substances are substantially related to those findings. And you can see here, and this is over the same period of, this is a suicide mortality from 1999 to 2013. Each area, different colors, a different part of the US. And for each area, you can see that for every 1 point increase in suicide mortality, there's been about a 2-point increase per 100,000 in poisoning mortality. And when you separate this a little bit further, again, the other key data here is, for example, you see here for drug and alcohol poisonings, for high school or less, you see a very, very substantial growth. Less so, this is again ages 50 to 54, less so with some college, less so with the BA. Likewise for each category, alcoholic liver disease and cirrhosis, suicide, and obviously the drug and alcohol poisoning. This is a map of the United States looking at drug poisoning mortality by county. In the US, you'll notice the red is the areas where the greatest drug poisonings are clustered. This, for example, here, where you have among the most dense areas is Appalachia. You notice Massachusetts actually is pretty high compared to almost every other place in the Northeast. It's particularly clustered in Rhode Island and Southeast Massachusetts. Interestingly, and again, you'll see some in the West here as well, and particularly in rural areas, much more than in urban areas. And then you'll see here, this is the suicide rate by county in the US, 2015. And there is some overlap, but there's some variability. So for example, here you see a growth in Appalachia, you see a fair amount in the West. Part of the reason the rate for suicide is so high in the West, and Mr. Rosenthal mentioned this. So, and again, I don't know the exact number of gun deaths that there are this year, but the last year I saw numbers for was about 30,000+. Of the 30,000 gun deaths in the US, 10,000 are homicides, 20,000 are suicides. And the areas where the highest cohort of guns are available are associated with higher rates of suicide. And this is clearly related to harm reduction or the opposite of harm reduction. You know, there's a famous study that was done in the mid-1960s or 70s, I think, in the UK. It used to be that individuals in the UK, when they would kill themselves, would literally put their head in the oven because the ovens had coal gas, and coal gas had very, very high carbon monoxide levels associated with it. And about 2,500 people killed themselves every year in the UK with coal gas. When coal gas was replaced by natural gas, the aggregate rate of suicide went down by about 2,000. There were still about 500 suicides from that cohort, but people used other means. But other means don't always translate. It's the availability of means in a period of crisis that's very substantial. That's part of the reason why the West here looks so problematic in the US. This is from Nora Volkow, who spoke yesterday, and my good friend Maria Kendo, who's the chair of psychiatry at the University of Pennsylvania. And they looked at some of the data, it's from the New England Journal of Medicine from this year. They looked at some of the data associated with suicide and opioid overdoses. And they looked at data from the National Emergency Department sample that said that only 54% of overdoses were classified as unintentional. 26% and almost 27% were deemed intentional. And this is a quote from their article. These data suggest that the true proportion of suicides among opioid overdose deaths is somewhere between 20 and 30%, but it could be even higher. So the numbers that we see, remember, are those things that are reflected in death certificates, medical examiner reports. This is another recent study from Mark Olfson and colleagues at Columbia. They looked at the causes of death, of what kills people in the next year after they've had a non-fatal opioid overdose. And in the 12 months associated with a 12-month follow-up after opioid overdose, this was against the standardized mortality rate. Remember, the standardized mortality rate is always 1. So the all-cause mortality, if you have a non-fatal overdose in the next year, you're almost 25 times more likely to die from some cause or another. Of those causes, 132 times more likely to die from drug use-associated diseases, 45.9 from HIV, 41.1 for chronic respiratory illnesses, 30.9 for viral hepatitis, 25.9 for suicide, so 25 times more likely to die from suicide. Again, a cohort of illnesses and diseases, many of which are associated with one form or another of behavior or associated with other mental disorders. So this is another interesting study. This is from the Veterans Administration. Now, I don't love electronic medical records as much as the next person doesn't love them, especially physicians don't like them. It's really not a lot of fun to sit with a patient and then feel like you have a taskmaster that's an electronic medical record that's basically forcing you to scribe in a lot of information when you went through 15 years of training to actually listen to people and take care of them. It's great to hire scribes to do that if you don't mind having other people in the room with you, but doing it as a kind of steady diet, a lot of us have the experience, you go see a doctor and they're staring at the screen, they're not talking to you, they're not paying attention. One of the positive sides of electronic medical records is you get a lot of data, and if you look at that data carefully and well enough, you might actually be able to do something with it. Now, the VA has a really, really good data system. First of all, everyone in the VA is on it. They have an electronic medical record. Secondly, they don't isolate substance use, mental health, and general medical records, and they're all under the same coding and identification system. In a lot of the general healthcare systems in the world, things are carved out to fourth parties. They don't talk to one another. It's hard to get this kind of information. So the VA used their database to create what they call the STORM model, which is basically a stratified risk model to figure out who was at risk for opioid overdoses within the VA population and what could they do associated with that to have risk mitigation. And because they've got data from everyone and they knew who overdosed on opioids, they could go back and they could basically massage that data and come up with an algorithm that would be hopefully predictive. And this is what the algorithm shows. It shows, again, the relative risk of certain factors in the medical record that lead to a greater risk of opioid overdose. And by the way, they can query the system every night, and every doctor in the VA can get an alert on their desktop when they come in the morning about every patient that they have who the algorithm says is at high risk for suicidal, for opioid overdose. They actually, in a one-year period of time, dropped their opioid overdose rate by 50%. And I would suggest that this is the kind of algorithm and capacity we need, frankly, for every doctor and every patient in the US. It's a little complicated to get to that, but it shouldn't be impossible. So what does the data show? So the relative risk if you have medical comorbidity is relatively low. If you have HIV, other kind, liver disease, other neurologic disease, it's about twice as high, but not extraordinarily high. If you have psychiatric comorbidity, for PTSD, it goes from 2.6 to bipolar disorder, depression, or other substance use illness or stimulant use, goes between about 5 to 6 to about 8 times higher. Highest for people who have a substance use disorder, about 11 times. And then if you look at healthcare utilization, it really, really goes up. So if you've made a suicide attempt or an overdose, 23 times higher. If you've been in detox, 18 times higher. And if you have an inpatient mental health admission, not an inpatient substance use admission, inpatient mental health admission, you're up almost 16 times higher in terms of risk. So again, we've spent a lot of time and energy to get doctors to do a better job in prescribing opioids to a lot of people in the population. And there's good reasons to do that because a lot of those drugs would get and do get diverted and will end up on the street. And some portion of those individuals will get addicted to opioids. But a lot of people who we're managing and taking care of are not the ones that are necessarily at highest risk. Those highest risks do cluster in certain groups in certain areas. So one other study that's from a little bit of a different direction, but again points to something about this connection between mood disorders and opioids. This is a study that my good friend Alan Schatzberg just recently published at Stanford. I will have you notice, by the way, this is just coming out online in December, so this is online first. If you look at the third author there, there's a Dr. Christine Blasey. I think we may have heard her name as Christine Blasey Ford recently in the recent hearings around Justice Kavanaugh. So she's the third author on this publication. So ketamine is a drug it's an anesthetic agent that acts through a particular receptor, the glutamate receptor, but it also has a certain amount of opioid activity. It actually is a drug that in East Asia in particular is one of the most common drugs of abuse, but it's also a very, very valuable anesthetic. In 50% of the world, the only anesthetic that's available for various procedures is ketamine. So if you're in sub-Saharan Africa and you need to take care of a kid and set a broken bone, what you have is ketamine. So there was an attempt within the UN. The Chinese wanted to reclassify it as Schedule 1 because they have so many problems with it. That was fortunately knocked down. But it's a drug that has a history of both effectiveness as a pain agent, anesthetic agent associated with procedures, and it's also really, really known to be a drug of abuse. Recently, and the NIMH did most of these early studies as well as a group at Yale, ketamine has been found to have a very, very rapid and beneficial but short-term effect in individuals who are severely depressed and suicidal in emergency rooms and other settings. And you may have seen things in the newspaper now about ketamine clinics that are popping up all over the place where there's really a relatively uncontrolled use of this agent. But there's something interesting about ketamine. It's important. We need to understand what the signal is that it's telling us, because most of the agents that we have associated right now to treat depression take a long time to work, and people can be very, very at risk from either medical complications or suicide while they have very severe depression. So it's an important study. But Alan Schatzberg noted the fact that ketamine's also a mu-opioid agonist. It works on one of the opioid receptors in the brain. And what he did was he gave individuals who were at risk who had high levels of depression, a randomized trial, and half the group got ketamine and placebo. The other half of the group got ketamine and naltrexone, which blocks the action of opioids. And as you can see in this next slide, the individuals who in the orange, who got the naltrexone, which blocks the opioid effect, essentially had no impact of the ketamine. So again, there may be something as opposed to the individuals who didn't get it, who had a robust antidepressant response. There may be something in opioids that we have not fully explored yet that is relevant for mood disorders, and not suggesting that they should necessarily be treatments for mood disorders, but they may give us some clue to some of the abnormalities that are associated with mood disorders. So I want to close with a different perspective and maybe bring us somewhat circuitously back to the issue of the two arrows, the bodily pain and the mental anguish that people experience and their interreaction. So this is a set of slides. This is a slide that shows the change in the Republican margin between 2012 and 2016 in the US elections. And you notice, for example, a lot of rural areas, the West, Appalachia, big changes. Just to remind you, that's the slide that shows the drug poisoning mortality by county in 2016. Not an exact overlap, but some relationship. This is a study from the American Journal of Public Health, 2017, showing mortality and voting in 2016 in the presidential election. And for individuals where the mortality was, the changes in life expectancy was less, in other words, people were not living longer as they are in most places, like we showed you in Europe, et cetera, and actually even most parts of the US, or changes in life expectancy over the 20 years plus years between 1980 and 2014, those individuals had the highest rate of voting for President Trump. So voters in counties in which life expectancy stagnated or declined between 1980 and 2014 were much more likely to vote for Trump, figure 1A. The weighted correlation between the change in life expectancy and the proportion of voting for Trump was 0.67. So that's a reasonable correlation. It's at the 0.001 level. 781 counties in which life expectancy increased by less than 3 years, as opposed to the average, which was higher, saw a 9.1% increase in Republican vote share. And this is a similar study that was done by Lee Goldman. Lee Goldman is the dean of the School of Medicine at Columbia. And it's independent relationship of changes in death rates with changes in U.S. presidential voting. This is from, I think it's Journal of General and Internal Medicine 2018. And this is a kind of busy slide, but basically what it shows you is that the age-adjusted death rate per 100,000 and the correlation with the net Republican gain, and particularly here you see the trend line going up like that. Rural areas particularly had a very, very significant change. Large urban areas did not. Counties with an increased Republican vote percentage in 2016 versus 08 had a 15% higher 2015 age-adjusted death rate than counties with an increased Democratic voter percentage. In a multivariate analysis, Republican net presidential gain in 2016 versus 08 was independently correlated with slower reductions in a county's age-adjusted death rate. So back to this notion of a second arrow. I think it's not unreasonable to recognize that we are in a complex crisis, obviously, around the use of opioids and deaths associated with opioids. I would argue we have a pretty significant crisis around suicide in this country. I think it's undeniable we have a very severe crisis associated with gun deaths, and we still have a clustering of many, many other forms of death in areas, many of which are associated with certain kinds of behaviors, such as drugs, alcohol, injectables, et cetera, that are associated with cirrhosis and other chronic obstructive pulmonary disease, et cetera. I mean, we talk a lot about the stigma associated with substance use and how people are responded to. There are lots of individuals who smoke cigarettes for 20 or 30 or 40 years, end up with lung cancer or chronic obstructive pulmonary disease or heart disease. We don't quite see the same stigma there, but we know from a lot of epidemiologic work that the impact of behavior, broadly speaking, drives an enormous amount of not only cost, but morbidity and mortality in the U.S. And that's particularly significant in people with serious mental illness. Individuals with serious mental illness die about 15 to 18 years younger than their age-matched cohort. 2/3 of that is due to medical causes. About 1/3 is due to suicide, other medical causes. So I would suggest that we have a crisis of, to some degree, of meaning, purpose, sense of self, which has been clustered in part because we know where these rates have gone up so dramatically in terms of the opioid epidemic, in individuals who've lost their sense of purpose, their way forward, and their sense of what it means to be who and what they thought they were in the United States. And that part of the work that we need to do is obviously make our physicians and our general public smarter about the use of these agents. Part of this has to do with the need to treat coexisting and comorbid mental health disorders, but part of it is also to understand that whether we like it or not, or feel sympathetic or not, there are a lot of individuals who are hurting right now and can't see a way forward, and that has pretty broad impacts and implications for all of us. By the way, this photo, just to close, is from Anming, China. It's a rural area outside of Kunming. They have great cell phone service wherever you go. They're spending a lot on infrastructure. It's a Buddha that's carved from a single block of wood, a single tree. There are 20, there are 2 others next to it. Those 3 represent 3 of 20 such Buddhas that are left in all of China, and they're unbelievably extraordinary in person. The photos do not do them justice. Thank you very much.